Hello, and welcome to our on-demand series for telehealth in practice. I'm Dr. Ted Hudspeth, and I will be your presenter for today. Today, we're going to be talking about billing in telehealth. And I want to let you know that we have an entire series on basically how to implement a telemedicine program in your practice. We have all of these topics that are included, and they are not only some live webinars that we did, but also some on-demand videos. And this is actually one of them, which is the telemedicine billing portion. So this is actually being funded by TxLaw Telehealth Resource Center. This was funded by a HRSA funded program at Texas Tech University, and is designed to provide technical assistance and resources to new and existing telehealth programs in Louisiana and Texas. TxLaw is partnered with Well Ahead Louisiana to serve as the supporting representative for the Louisiana providers. TxLaw is also part of the National Consortium of Telehealth Resource Centers. You can access the websites and resources from all of the TRCs across the country through the consortium website, which is telehealthresourcecenters.org. And I am your host, Dr. Ted Hudspeth, and you can read all about me later, but I will leave that on the PowerPoint that you can also download from our site. So to start off with, I'll have a little cartoon here. I hear there's a new ICD-10 code for carpal tunnel syndrome caused by clicking too many times in an EMR system. Well, many of us probably have developed this ICD-10 code for our own health because of how much we have to click and how much we have to do to actually bill for our services and document our services. But there have been some changes recently that I think somewhat helps ease some of those burdens. At least that's what they were designed to do. So I'm going to go through some of those changes that have occurred in general, and also then drill it down to the telemedicine component. So as for an overview, we'll look at statistics. I will go through the 2021 documentation and billing changes and discuss specifically medicine decision-making, time billing, and some additional guidelines that go into all of those changes. And then I'll drill it down to the telemedicine specific billing, go through some definitions, and then discuss reimbursement specifically for virtual and telephone visits, e-visits, e-consults, modifiers, remote patient monitoring, and then chronic care management. Specifically on the chronic care management and remote patient monitoring, we have had some other presentations in our webinar series that you might want to go back and look at to learn some more specifics on how you actually implement those particular types of services in your practice for telemedicine. So let's go through some of the statistics here. As far as healthcare costs, 17.8% of the GDP for the United States in 2019 was healthcare related. And CMS projects that this will be 20% by 2025. Now, I'm not even sure if that includes all of the costs that we have incurred with the pandemic. So it may even end up being more than that. But what is concerning is that health outcome goals have not even been achieved. Even though we're spending that much money, we are not achieving the healthcare goals that we should be achieving. And there are some reasons for that. Part of that is the fragmented care that our system currently has. And I personally believe that the many ways that we can connect with people through telemedicine now, both in synchronous and asynchronous visits, I truly believe that we will be able to achieve some of those goals better, or reach those goals better. And with all of the billing changes that have occurred, we actually are now going to be paid to do those types of services, some of which we have been providing without billing for many, many years. Also, lack of access is a problem which delays care and inhibits some people from even getting care to begin with. And again, I truly believe that with telemedicine and the way that we will be able to reach out to people and connect with them where they are, when they need, then this will allow us to reach our goals better. And also adding asynchronous visit capabilities will also allow us to get people the care they need, when they need it, and how they need it. And then also being able to reach out to consultants to be able to bring in specialty services intra-professionally. This will allow us to bring our patients a higher level of care and service them in ways that they've never been able to be serviced before. So the AMA projects that there will be a physician shortage by 2030 of between 40,000 to 100,000 physicians. So this is another reason why we are projected to not be able to reach all of our health goals for our patients in the future. But again, I truly feel if we can improve efficiencies by employing some of these telemedicine techniques for which we now have billing capabilities, we will be able to help people achieve their healthcare goals. So this is just a graphic of where we currently are projected with the telehealth global market value going from 2.78 billion in 2016. This year alone, it's projected to be 9.35 billion. And again, some of this was spurred by the pandemic, but I feel that this is going to increase over time, basically because of user demand. Patients are going to demand and prefer to utilize telemedicine type services in the future. So there were many 2021 documentation and billing changes, and I will go through some of those right now. The main objectives of these changes was, number one, to help reduce administrative burden of documentation and coding. So it makes it a little bit simpler. It will decrease the need for audits for CMS and other auditors through the addition and expansion of key definitions and guidelines. It will improve payer accuracy for what actually is being done at the visit and the work that's actually being done. And it will update the office and outpatient E&M visit code set to really better reflect the current practice of medicine. A lot of what we do is not just seeing the patient, it's reviewing data. It is making shared decisions with patients and discussing those types of things. It's actually coordinating care. And all of those things can now go into the decision-making process of how the billing is done. What is not changing is inpatient codes are no longer covered. Observation codes are not covered. ER room codes are not covered in this change, and also skilled nursing codes are not included in any of these changes. So when selecting a level of service, going through some of these things, I'm just going to go between the previous state and the current state. So in the previous state, your history, exam, and medical decision making was all part of how you calculated everything. As of January 1st, your medical decision making or the total time documented or total time that you spent is really how you make your decisions on the billing level. Previously, it was actual face-to-face time with the patient. Now it's the total time spent on the encounter, and it's not just the face-to-face time. So if you want to click in the PowerPoint and actually go forward to the slide that goes through all of this time-defined area, you can do that, but we will review it later on in the video presentation. Previously, we could either document that 50% of the time spent on counseling and or coordination of care had to be done if you were billing through that particular mode. Now, documentation of 50% of time spent on counseling and or coordination of care is not required. So you don't actually have to put that in. If you're doing the total time that you spent with the patient, you can actually use that entire time. And then 99201 cannot be billed because that actually doesn't involve a provider doing any kind of activity. So while it could be billed before, it has been deleted in the new system. And then before there was a table of risk, and now it's a medical decision-making table. And I'll provide that for you later on in the PowerPoint. So when you select a level of service, the level of decision-making as defined for each service can equal the total time for evaluation and management services provided on that date of the encounter. So you can either go between each one of those, and it is really kind of similar. So we'll talk more specifically if you're going through the medical decision-making billing level of this. We'll kind of go through those. In medical decision-making in the office and other outpatient services, your code is set by basically 3 different elements. The number and complexity of problems that are addressed during the encounter can be part of that. And so, we often have 3 different problems. And if you're having lower level of complexities, but you can have one problem that is very complex. And actually, you have higher levels of coding. The amount and complexity of the amount or complexity of data to be reviewed and analyzed is actually divided into 3 different categories. So category 1 is you could have tests, documents, orders, or getting information from independent historians. Each one of these can be utilized when you're looking at a data point number 1. And of course, if you have independent interpretation of tests, that could be a data point. Now, if you are billing separately for interpretation of that specific data, you cannot include it in your E&M coding for your actual provision of care on that specific day. But if you're independently reviewing data and using that as part of your visit itself and not billing that elsewhere, then you can utilize it as one of your complexity data points. And then, of course, discussion of management or test interpretation with an external physician or other qualified healthcare provider is also a potential data point to include in that. Now, that would not be if you are doing some sort of a billing for something like an e-consult or something like that. But if you're doing some shared decision evaluation and management with an external provider, then that could be a data point. And then the risks of complications, morbidity, or mortality of the patient management decisions made at the visit can actually be associated with the patient's problems and diagnostic procedures and treatments. That is another billing point that goes into your medical decision making. A very complex patient obviously would be a higher billing code than if you were using or treating a patient with lower risks and lower morbidities. So, of course, this includes the possible management options selected and those considered, but those that are specifically not selected, like that if you considered something but didn't select that in, then that's still something that you can include in your decision-making process. Because sometimes you have to consider problems, but then exclude them from what you're actually doing. But that's still part of the work that's being done. And then there are 4 types of decision-making processes that are recognized. It could be very straightforward, low risk, moderate risk, or high risk. And the concept of the level of decision-making does not apply to 99211. We had talked about that earlier. And that's because that doesn't include a provider. And then shared medical decision-making involves eliciting patient or family preferences, and then the patient or family education, and explaining the risks and benefits of management options. So if you go through all of that process to make a shared decision, that is another data point that can be included in your medical decision-making process of determining your billing level. Okay, so that is also something that is included, and that may or may not be face-to-face time. It can be provision of information that ultimately results in a shared decision being made. And then when the physician or other qualified health professional is reporting a separate CPT code that includes interpretation of a report, basically you cannot include that in your medical decision-making for your actual visit. We discussed this earlier. So if you had a specific test that you did on a patient and you billed that separately, then you would not include that in this billing. And when the physician or other professional is reporting a separate service for discussion of management with a physician or other qualified healthcare professional, you cannot include that in your billing time for your E&M of your actual visit. So for instance, if you did a separate e-consult where as a PCP, you placed an e-consult to a specialist and you billed for that, then you would not include that in your E&M coding for your visit that day. So again, e-consults are a very special area that we will review later in this presentation. So I included some graphs here for you to be able to review and basically match up your particular coding levels. I'm not going to go through all of these. I'll just provide it for your information. But the elements of medical decision-making, if it's either straightforward or low complexity, that's what's included on this particular page. And of course, if you have a moderate complexity, then these are the elements included in that level of complexity. And if your medical decision-making is of high complexity, this is your list of things that need to be included in when you are billing at that level. And there are some examples in each one of these that you can go through to be able to see how you match up. Okay, so that was if you're billing based on medical decision-making. You can, under the new system, bill just on time billing. And if you're defining the time, this is what I had referenced earlier, this list. Basically, the things that are included in this include preparing to see the patient. So if you review tests, notes, charting, etc., from other providers before you even go and see the patient, that's included in the time that you bill when you're doing time billing. If you're obtaining or reviewing separately obtained history, then that's included. So for instance, if the patient includes or the nurse includes history on the particular illness that's being evaluated at that time, then you can include that in your time overall. If you and when you perform your medically appropriate exam and or eval, that is included in it. And then documenting clinical information in the EMR or other health records. So the time that you spend actually doing all your documentation is included in that. And then if you independently interpret results not separately reported and communicate those results to the patient or family, then that can be included. Now, that's if you're not doing billing for that particular interpretation through some other means. Okay, you can't double dip on that. And if you're doing care coordination with another provider or institution or any other people, then you can include it in all of this overall time. And of course, ordering medications, tests, and procedures. So that's actually inputting your orders. And then referring and communicating with other healthcare professionals when you're not separately reporting that. So for instance, that wouldn't include if you did an e-consult like I was discussing before. But if you're arranging transfer of care to another facility or another physician or another provider, then you could include all of that in your billing when you're doing it through a time-defined entity. And this is the total time for E&M services performed on the date of the encounter. Again, it's not just face-to-face time. And this is a list of the timing of that you can utilize for your billing services. And some additional guidelines that you can utilize is that on your history and or examination, the office and or other outpatient services include a medically appropriate history and physical exam. So you don't have to put all of the data points from all of the body parts. If you are doing specifically a directed exam that is appropriate for that particular complaint that day, then that's really what's needed. You don't have to put all of those other points in there. And then the nature and extent of the history and our physical exam is determined by the treating physician or other qualified healthcare who is actually reporting the service. So it's actually the time you put in doing those types of things. Your care team may collect information and the patient or caregiver may supply information directly. So for instance, if they input data in a portal questionnaire or the nurse inputs history in there and then you review it, then you can include it in that note. You can include it in your time that you did the review on that particular data service. And the extent of the history and physical exam is not an element in selecting the office or other outpatient service. So in your billing codes, you don't have to include all of those bullet points that we used to have to do. It needs to be very focused and include the pertinent information that you need to make a decision based on your history and your physical. Now, if you have prolonged services with or without direct patient contact on the date of an office or other outpatient service, there are codes for that. So code 99417 is used when you are reporting a prolonged time. So if you combine the time with and without direct patient contact, then you can use that particular code to be able to bill for your additional services that are used. And it can only be used with 99205 or 99215, okay? You do not report any additional time that's less than 15 minutes. So it must be at least 15 minutes when you're doing these types of additional timing. And the time spent performing separately reported services other than an E&M service is not covered toward the time to report your 99205 and 99215 and the prolonged service time. So when you're looking at the prolonged services with or without direct patient contact, then you can look at this particular grid and be able to show the levels of time that you actually added in based on those baseline codes. And some things to remember is that physicians and other qualified health professionals must only document that they reviewed and verified information regarding the chief complaint and history that is already recorded by the ancillary staff or the patient. This is what I was alluding to. A patient can fill out an online questionnaire concerning their problems, and you just have to document that you reviewed and verified it, okay? You don't have to go back in and type all of that again, which is a big help to make things a little easier. And your history exam should be appropriate to the presenting problem itself. You don't have to have all the other bullets filled in to be able to document appropriate coding. And if you're billing based on total time, both your face-to-face and non-face-to-face time is used in determining your level of service. So this is great because before it really did not take into account all of the additional work or the time of work that was required to be able to care for a patient. So those were some general overviews of all of the changes with respect to billing in general. What I'm going to talk about now is really telemedicine specific in your billing. So first, we're going to go through a few definitions. And some of these definitions really were, I guess, more important before we had the pandemic and before telemedicine just, it basically went to coding like we were face to face. In days past, we talked about originating place and things like that, because a patient had to be in a specific place to be able to receive telemedicine benefits where they were actually covered by the insurance. So for Medicare, location where a Medicare beneficiary, that is the patient, connects with the physician or practitioner through telehealth, that really mattered, okay? And the beneficiary must go to the originating site for the service to be covered. And this is where we're defining, originating site. And they divided that up between whether a county was outside a metropolitan statistical area, MSA they call it, or if they were at a rural health professional shortage area, that's an HPSA. And basically this was in a rural area. And a patient had to be in a specifically eligible site for any of these services to be able to be covered by them. The Health Resources and Services Administration basically was the group that would decide where an HPSA was, and the Consensus Bureau decided what an MSA was. And you can determine or go and see specifically what your area is considered by going to this link on this website, where you can see HRSA's Medicare Telehealth Payment Eligibility Analyzer, okay? So you can go and determine that for yourself. So eligible originating sites included a physician and practitioner office. If you basically had to be geographically, you were limited, and it would not apply to all facilities. You had to be specifically in one of those areas that I was describing before. Hospitals were covered, and critical access hospitals were covered. Rural health clinics were covered. Federally qualified health centers were covered, and hospital-based or CAH-based renal dialysis centers were also covered. Skilled nursing facilities, community mental health centers, and renal dialysis facilities were covered. And homes of beneficiaries with end-stage renal disease that were on home dialysis were covered. Mobile stroke units were covered, and the home of a patient receiving treatment for basically opioid abuse and co-occurring mental health disorders was also covered, all right? So that was how you basically defined eligible originating sites. Now, they also had a qualification or a definition for a distant site, and Medicare does not provide a definition of where a distant provider site is, but does limit the type of provider who can provide those services. So physicians, nurse practitioners, physician's assistants, nurse midwives, certified registered nurse anesthetists, clinical psychologists, clinical social workers, and registered dietitians or nutritional professionals could bill as a distant site if they were that type of provider. Providers cannot be located out of the country when providing these types of services, though. So a lot of that changed with the pandemic. All of a sudden, patients needed to be seen, and they couldn't safely do that in our offices when the pandemic hit. So a lot of that has really changed and opened the door wide for our billing. A nice article is linked here where you can go in and see telemedicine coding reimbursement, current and future trends. It's a nice article, and if you want to basically teach yourself some of the thoughts of where we're going in the future, you might want to review that because it's really done well. But our innovation in technology has really redefined how we are providing services. And right now, our billing is kind of catching up with that, okay? And patients want convenience and quality. the technological advances that we've had are allowing us to do that. And thank goodness the billing is, again, catching up with that. Telemedicine technologies and asynchronous provider to patient communication is really flowing together here. And again, as I stated when I first started this, I truly believe this is going to allow us to service our patients better, to give care where people need it, when they need it, and how they need it. So it's going to connect us better, and it will improve. Because of the improved access, I feel that it will provide a better value of care. It'll help us decrease costs, which is definitely needed in today's society, and it will enable patients to better, more directly be involved in their care and work on their health themselves. I think this has been needed for a very long time. It's just not us providing the information for them. It's actually involving patients in their care and giving them the tools that they need and the connection that they need to do the things they need to remain healthy and to keep up with their health. Our telehealth coding and reimbursement rules are specifically payor and state dependent. So while some entities, some insurance companies may pay for e-visits right now, some may not. And some states allow you to do certain things or connect with patients in certain ways, and some do not. So you do have to make sure, if you're with various payers, that you find out how they pay you for various activities. And if you're watching this from various states, you need to find out how your particular state manages these things. So just going through a few of the reimbursement designations, telemedicine is considered a synchronous activity where you're doing a live, either video-based or telephone-based service, but it's synchronous with the patient at the same time. As far as a distant site, the location of the physician or other qualified health professional at the time of service being furnished is at a distant site from where the patient actually is, and you're communicating, through video and audio. The originating site is considered the location of the patient at the time of the service that is being furnished, and of course that's been expanded now with the pandemic. The patient can be just about anywhere. You need to start looking at your specific state rules and your medical society's rules for whether you can practice in state or out of state. So basically a patient, in most situations, a patient needs to be in the state that you're licensed in to be able to provide the services to them, okay? And then a physician or other qualified health care professional is a physician or other professional is a person with education, training, licensure, and regulation and facility privileging who performs a professional services within the scope of their practice. Okay, so you must be practicing within the scope of what you were trained and licensed to do. And then there's this newer thing with asynchronous telecommunication. And I think this is really going to expand the care palette, so to speak, of how we can provide care to a patient. And this is where medical information is stored and forwarded to the reviewing physician or healthcare practitioner at the distant site. And the medical information is reviewed without the patient being present at that time. It's also referred to as a store and forward telehealth or non-interactive communication. So this is where you can look at e-visits as an opportunity to be able to care for your patient. We've reviewed e-visits in other presentations, but that's basically where the patient is sending you information, you're evaluating it, making a management decision, and then giving that back to the patient asynchronously, without them being physically or telephonically in front of you at the moment. When you're looking at reimbursements, everyone pretty much has, a large number of groups between self-pay, employer pay, Medicare, Medicaid, and Medicare Advantage plans and private payers that are all now doing telehealth. And there are specifics that you can work with on each one of them for levels of payments and things like that. But the coding is going to all be the same. So let's just look at virtual and telephone visit billings. When you're doing an e-visit, basically, it's basically like what we consider a typical virtual visit. It's a video visit, and those use codes 99201 to 99205 for new patients, and 99211 all the way up to 99215 for existing patients, okay? And this is basically a physician or other eligible provider that we've talked about before. And CMS has basically established a wide range of services to be able to be delivered through that particular method. And of course, there's the telephone visit now, and originally and currently this is still considered a temporary type thing, but it's basically a way to be able to deliver care through the telephone. And this is really established more so for folks who do not have video capabilities. You know, not everyone can connect with you through a video visit. They may not have the equipment, know-how, or the bandwidth where they live to be able to connect. So thank goodness CMS has allowed us to have these coding changes to be able to allow us to bill for services, because there are many things that we care for through a telephone visit. And this will actually allow us to be able to do that. So in a telephone visit or a brief check-in, that is a G2012, and those codes end up going between a 98966 to a 98968. And basically those are where a qualified non-physician can do some billing. But if you're going to be a provider, then that's going to be a 99421. I'm sorry, on the 99421 to 99423, those cannot be billed more than once per 7-day period. So if you're going to do a telephone check-in, within 7 days, if you see the patient, then you can't do that billing. The goal here is if you can manage something via telephone and it doesn't result in them having to come in, then you have given a level of service that should be paid, okay? But it can't be linked to another visit for that same problem within that time frame. And then for your e-visits, this is an online digital evaluation service. There are various codes here, and if a qualified non-physician healthcare provider does an online assessment for an established patient for up to 7 days, cumulative time for 5 to 10 minutes, then you see the 98970 applies there. A 98971 is where a qualified non-physician healthcare professional does an online assessment, and it lasts between 11 to 20 minutes. Then that is the code that you use. A 98972 is where a qualified non-physician spends 21 or more minutes evaluating and caring for the patient. And then a 99421 through a 99423 are for practitioners who can independently bill for an E&M service. So think of this as for instance, a telephone message comes in, and if you have specific e-visit billing and you do the appropriate consent for the patient to be cared for through this manner, then an e-visit code can be utilized based on the time that it takes you to do this type of activity, okay? And then a 98970 all the way to a 98972 are for practitioners who cannot independently bill for E&M services. So looking at specific e-visits, This top area here where you have online e-visits, that's that 99421 to 99423. That's basically where you have an exchange of secure messaging and it's linked to a related E&M service. You cannot do the billing. But if you are preventing the patient from having to come in and you're caring for that patient, then that's where these billing codes would apply, okay? So that's if you're doing e-visits. Now there's a new concept of e-consulting. Basically, this is payment for an intraprofessional, basically a sidewalk consult between two providers. It is intended to be for a primary care provider to compile information, reach out to a specialist for evaluation and management recommendations, and then taking those recommendations and caring for the patient. So they actually have codes on the consulting end where the primary care provider can do billing. And there are also codes on the consultant's end. So the beauty of an e-consult, or the intention of this, is number one, it formalizes the sidewalk consult. You know, in the old days, in a sidewalk consult, usually the consultant didn't have access to the entire chart or the information. The consultant did not do any documentation. And in those scenarios, I think patient care was not as good as if the consultant had access to all of the information, could make a better recommendation, could do documentation, send that to the primary care provider, and then the primary care provider act on that information in an appropriate way. So in this particular method of care, both parties are paid, and there's, I think, better care being done. But in this process, the patient has to be consented. They have to understand there may be some charge for this. Many insurers do pay for this process. You have to have a formalization of the process. So basically design a workflow between yourself and your consultants so that everything can be appropriately documented. So to go through this in more detail, on the primary care end of this, a 99452 is what a primary care provider would bill for if they have 16 minutes of time that they spent in organizing all the information and then getting that to the consultant. The 99452 cannot be reported more than once in a 14-day period for a patient. So you need to keep that in mind. And then on the consultant's end, the person who is consulted, there are various codes that can be utilized there. And that ranges anywhere from 99451 and all the way to 99449. So in this, it's basically a time-based situation. And it also involves whether or not the specialist personally spoke with the consulting PCP. So a great little grid here kind of summarizes that. If you look at the bottom, this is where the 99452, this is the treating or requesting physician spends greater than or equal to 16 minutes of time preparing the e-consult and the actual time spent communicating with the consultant. And then if you go up to the top, everything here is based on the consultant's work that he or she does. If you see that the 99446 is for 5 to 10 minutes with reviewing medical records, imaging studies, medication, etc., and then providing verbal or internet discussion, then they would bill all the way through to 99449. If they only give a written report and it's greater than 5 minutes, then they would report a 99451. That's when they do not have any verbal connection with the treating or the requesting provider. And so there are some modifiers to be able to think about here. A modifier is based on information provided by the AMA. And basically, these are two-digit numbers or two-character modifiers or alphanumeric indicators. And they provide additional information to payers to make sure that your provider gets paid correctly for all of the services that are rendered. And more than one modifier may be used with a single procedure code. However, they are not applicable for every category of CPT codes. And some modifiers can only be used with a particular category, and some are not compatible with others. So if you're going to look at modifiers and place of service codes, the GT modifier is describing a telehealth service via interactive audio and video telecommunication services, okay? And then a GQ is a telehealth service via asynchronous telemedicine systems. So we've talked about that asynchronous type of visit. And then a 95 modifier would be utilized when a synchronous telemedicine service rendered via real-time interactive audio and video telecommunication systems are used, okay? And then, of course, you can look at modifiers for places of service. An O2 is utilized in telehealth when the location where the health service and health-related services are provided or received through a telecommunication system. So again, this is like a distant site provider. The number 115072 is based on a normal place of service code for the facility, and that's really the originating site. If clinics are doing remote patient monitoring billing, these go into great depth here on this particular grid, and I really would reference you to our chronic care management presentation that we did, because we really go into great depth on remote patient monitoring. But this is where you basically are monitoring patients through remote connections and basically providing services and helping them monitor particular diseases like hypertension or diabetes itself, et cetera, when they're doing some self-measurings of these particular activities. So these are all of your billing codes that you can use in those particular activities if you're providing telemedicine services. And then in chronic care management, that's a similar one that we did in that particular presentation earlier in the series. And you basically look at whether you're doing a lower or a higher complexity of monitoring and managing of 2 or more chronic problems. These are all the billing codes, again, based on time. And if it's a lower complexity and you're only doing 20 minutes of time, then it's a 99490. And again, these can be, it's basically time that your staff may be utilizing to care for their chronic problems per month. If it is 30 minutes of time, but still a lower complexity of care, then it's a 99491. If it's a very complex patient and they're doing 60 minutes of time, then it's a 99487. And the code 99489 is an add-on code, meaning you cannot bill it without a 99487. You're basically adding additional 30 minutes of time above your 60 minutes of time for that 99487. You can actually do an additional billing code to reflect the work that your staff and you may be doing when you're doing chronic care management of a really complex patient. And then G0511 is when an RHC or an FQHC is coding for the chronic care management that is being done. And so in summary, wow, I could have had a 99214. This little cartoon reflects that there are many things that go into coding. These things really need to be reviewed and understood because there are lots of things that you probably do in your routine practice and you never bill for it because maybe you didn't understand how you needed to bill for it. But you're really missing out on payments for work that you've actually done. So I encourage you to go through this and then go through that PowerPoint in detail to be able to see what you may be able to do in your practice, not only in your regular practice, because we reviewed all of those changes in the beginning of this, but then if you're going to do telemedicine, you need to know those specific levels of codes for a regular visit, and then also for some of these asynchronous type visits and e-consultations that we are all going to be doing in the future probably, okay? So as part of this series, we have resources at the end of every single one of our PowerPoints. We go through many different resources that I've collected over time in preparing for all of these presentations. And I will leave you with our contact information. If you want to contact the folks at Well Ahead, you can either email at wellahead@la.gov. And you can see all of the presentations that we've reviewed in this series at www.walpen.org/telehealth. And of course, you can communicate with me directly by emailing me at tedhudspeth@gmail.com. And I want to thank each and every one of you for joining us. Please share and watch all of our other videos. Thank you so much.